the call is new to BPM Plus Health, this is a new community that we launched in September 2019. And it's an open community initiative to improve the quality and consistency of healthcare delivery. Specifically, our focus at BPM Plus is on using open IT standards. These are business process and case modeling standards to model clinical pathways, clinical guidelines, and other healthcare knowledge to free this knowledge, make it computer readable, computer consumable, to be shared across health institutions, and to give doctors and clinicians, the information that they need to make better decisions and improve outcomes. So we're really have a great community going here. And at the bottom of the screen, you'll see these are our founding members that helped us launch a few months ago. And so the sessions that you'll hear today are all, they map back to work that's being done in BPM Plus Health working groups. We have these 5 working groups: authoring, adoption, implementer, methodology, academic, and professional education, that is helping us to advance our common goals, our common mission. So if you're interested in getting involved in participating actively or just saying, up to date with our work, visit our website at bpm-plus.org. And I'll show you that URL in a bit. It's also in the chat box. We'd love to have you. So the session that we're starting now, leveraging BPM Plus Health models to improve real-world coordinated care delivery. I'm joined by Ken Allgood and Ty Lamb from healthflow.io. So they're going to share the demo that they had put together at HIMSS. So Ken, why don't I hand the floor over to you to get started.
Okay, thanks, Tracy. Let's go ahead and find me on the Make Presenter list. Okay. And let's go. All right. Welcome, everyone. Thank you, Tracy, for the introduction, and thank you all for joining us this afternoon. This is a sort of a reduced footprint demo to the one that we had planned for HIMSS. Obviously not as interactive as we had hoped for, but nonetheless, I want to walk through how we're working with the BPM Plus community. I'm actually a co-chair along with Bo Dagnall for the Implementer Working Group, helping to put together some of the general practices and overall methodologies for how we can take these interoperable workflow models and the rules behind them and actually use them to drive actual better care. And from a health flow perspective, we built out a platform to be able to really kind of push forward the concept of patient-centric healthcare. And we'll be walking through our care coordination flow today and focusing on how we would interact and support that across a referral framework. So let's go ahead and continue. There we go. The problem, for those of us in the community that have been working in this for a while, we know that healthcare coordination, it's difficult, even in the best of circumstances. You're working across systems quite often, you're working across specialties, and it's difficult sometimes to bring that information together. And unfortunately, the existing EHRs and EMRs that are out there simply are not designed for patient outcome improvement necessarily. They're really not designed for healthcare. From the baseline, they were built for billing. Bottom line, over $78 billion in annual waste is tied to healthcare referral care coordination issues that impacts patient treatment outcomes. It impacts the availability of healthcare services and provider and payer operational budget and bottom line. It directly impacts our patients every day, and it directly impacts their outcomes. And the problem is growing. As the US population ages, care coordination needs will continue to grow exponentially. The care delivery is growing more fragmented as costs and system demands rise. The existing virus battle that we're in here in the US as well as across the world is a prime example of how these tipping points can arrive and really tax our healthcare system quickly. Existing care coordination solutions are largely tied to existing EHR EMR, limiting information exchange and interoperability. The majority of the solutions that are out there right now are really centered on the systems and the clinical care team, which is important. What it tends to leave out is the actual patient team, the team that's working with the patient, family, friends, sometimes consultants that are working with the patient to ensure that their care is carried through from point A to point Z. And most importantly, 80% of clinical errors that occur are due to a lack of coordinated communication during that care transition. Information passes within systems. Quite often it gets dropped. It doesn't make its way back to the primary care physician that started the whole thing. And it falls back on the patient and their personal team to actually make sure that all of those dots are connected. When you are a patient that's out there being treated for a complex care scenario like cancer, like a variety of other things, that becomes consistently more and more difficult as the treatment progresses. So we've built a couple of solutions to address that, and we'll walk through them. Care coordination in the real world. Patient health data is siloed, it's disparate, and it's quite often very difficult to assemble. The system IT is fragmented, and the federal and state regulations, that only adds to the churn. Existing care coordination solutions, as I mentioned earlier, tend to be clinical or system first, and the health data interoperability standards and government regulations like CCPR, GDPR, and information blocking continue to evolve. Other drivers that are pushing this forward, pushing this need forward, CMS and ONC finally released the rules earlier this week. Some of the key areas in there that have some teeth: the Patient Access API, Medicare Advantage plans, Medicaid Children's Health Managed plans, state agencies, all of these entities are required to implement and maintain an API to support patient access to the health information, and that's got to be in place by January 1st, 2021. The payer-to-payer data exchange, all of the patient's data needs to be able to be passed between payers as of January 1st, 2022. And starting in September 2020, the COPs for hospitals and CAHs require that they send the ADT event notifications to other healthcare facilities or community providers. Again, these implementations will require additional footprint, additional IT effort, and quite often if it's a small physician group or even some smaller systems, they don't have the IT personnel, they don't have the infrastructure to really support this right now in the way things are, and they certainly can't support this leap forward. Our solution, it incorporates active care coordination. As part of that, we have built upon industry standards for healthcare information and process interoperability. As I mentioned, I'm a co-chair for the implementer group for the BPM Plus Health activity. To be able to leverage BPM Plus Health models, we leverage those at the beginning. We leverage them to drive both the rules as well as the guidance that is given to the patient care team and the clinical care team as we run through the handling of the patient data and the overall treatment of the patient. We enable secure patient handoff at all points of the care coordination team, again, aligning back to those standard rules and elements that are tied to that interoperable care flow. And we empower patients to take control of the care through referral transparency, data visibility, and consent management. If you look at the arrow above, we verify consent. We ensure that the patient's actually given consent for the exchange to occur. We provide that visibility of exactly where the patient's data is going. We validate that the health data, and we bounce this off of the BPM Plus health model as well, to ensure that the baseline information, the context that's required for that health exchange, is actually satisfied. We highlight areas where that is not being dealt with, send messaging back to the individual providers to identify those gaps and make that information also available to the patient care team. Facilitate care delivery by providing visibility into the health data, by providing that visibility back to the context of the care model itself. We're able to provide a step-by-step visibility into the actual care delivery cycle in relation to best practices standards. And providing transparency, again, we're going to provide you end-to-end visibility into what's happening with the care team, where the patient is within that cycle. Again, the intent is to provide that visibility for the patient team as well as the clinical care team, and provide a level of transparency from end to end so that the PCP that might have kicked off a referral activity, a specialist visit, actually has visibility into where that patient is in that delivery of care cycle, and gives them a lot, some traceability as to how their patient is doing, making sure that they're actually achieving the follow-ups that they need and that they're getting the care that they deserve. We're doing this with a functional architecture that depends upon, we've engaged with several different partners to accelerate implementation as well as provide best-in-class capabilities. We're teamed with Red Hat for business process automation as well as rules automation, teaming with Wired Informatics for their clinical NLP and machine learning engine that gives us the capability to identify clinical context in large unstructured clinical data corpuses, being able to structure them then and make it available, align it to FHIR standards as well as others for exchange and delivery. We're teaming with Redox from an interface perspective. It enables us to actually interface quickly into new systems. If they're not compliant with particular standards, obviously we would prefer to leverage FHIR wherever possible. It makes it computable. It enables us to then align both the clinical data with the consent data and tie it to the evolving FHIR 4.0 standards elements. But we're teamed with Redox to enable us to interface with a variety of different systems and get interfaced quickly. And we're also teamed with Philips from a health data perspective, health exchange perspective, around devices. So that's one of our interfaces is leveraging Philips. Taking it from the top to the bottom, and we'll walk through the health flow application suite, specifically the patient team app and clinical care team app in a second. That interfaces through our exchange templates, leveraging the FHIR API as well as the custom interfaces supplied by Redox or ones that our team has built specifically. That data is then processed through the NLP and ML engine, as I mentioned. We're tying it to the clinical context, identifying those clinical concepts, and then structuring it to make it searchable and discoverable. We align that then to the requester, alignment tied to the specific BPM Plus template or other templates, again, tying it back to that clinical context. We encrypt that data for exchange and push through the selected interfaces required. You'll notice over on the right-hand side, the patient-specific blockchain governance. We are leveraging blockchain at the core, specifically for transaction management. No health data is stored on the blockchain, but that is our single point of reference. So we can, it also allows us to be GDPR compliant and CCPA compliant, because we can actually query against that specific blockchain instance for the patient and identify exactly every single transaction, where it's gone, where that data's gone, who it's been exchanged with, consent details, and such. And around the entire thing, we're running process automation. Again, that's being driven by the Daemon and BPMN Plus standards. That helps to inform that and then drives that off of the template elements as well. We'll be walking through a referral flow example. This is just a quick high-level view of how we at HealthFlow view a referral from the perspective of an initial PCP engagement. Initiated the referral request, we do a check as to consent. Within the patient app, you can select to provide consent to allow for that data to be passed on to the specialist. We bounce the actual request for data off of the clinical information that we have for that referral. Again, tying that back to the BPM Health standard wherever possible. We facilitate the pulling of that data, the compositing, and then the handoff of that to the service provider. We also provide that same enrichment, that NLP processing ML, bringing that data back to the PCP and providing those notifications back to the PCP as well. Again, the goal here is to provide visibility across the entire clinical care team of what's going on with the patient, ensuring that the intended treatment is occurring, that there aren't any roadblocks to that treatment, and if so, the PCP and the other members of the care team are aware of it. They can act, they can intercede on the part of the patient, and the patient's care team is also aware. So I'm going to hand it off to Ty Lam, our Chief of Product, to walk through a demo of the patient and clinical care team apps.
Hi, this is Ty. I work with Ken, so thank you, Ken, and thank you, Tracy, as well. You should be hopefully seeing my screen. What I have set up is the demo for you today. On the screen, you'll be seeing 2 different sign-ins. There actually will be 3. We'll be going through 3 different roles on here. The first one on the left will be the patient view. We'll have a physician's view, and then we'll have administration view for a health system. The way we're going to kick this off is going through from the patient, and the way we're going through this, as Ken had talked about, is in the very beginning, a lot of it is focused around the patient. We made the patient the core of the way we want to implement the data, as well as the flow and the presentation, the context. So from this point of view, what we said is the best way to approach a patient would be through a mobile website or a mobile app. And from this point, we can see here is we have this patient logged in. From their view here, they can see that they have items that might need their attention. They have basically information about their appointment that's coming up to set reminders for. So these are all pulled in from all the activities that they're performing for a particular physician or a particular treatment plan. The way we approach this for a patient's point of view, instead of having a singular navigation structure, we were looking at it in terms of how different patients might have a mental model of how they approach their medical activities. The very first part of this going on are those that look at activities in terms of events, like treatments in terms of appointments. They'll be able to see and go into, hey, I have one new event I need to take a look at, or events that have been updated, or a whole listing of my total events. I'm going to walk through all these individually, and I'll go back into here and start kind of clicking into them individually. From this point, they can also see their medical healthcare team. So these are the team, physicianal team members that they're actively, at this point in time, interacting with. So in this case, for this particular patient, we've set them up with an oncologist, their primary care physician, a gastroenterologist, a nutritionist, and then a lab. They are able to add additional care team members, both from a system or externally, and we'll be going through and adding one as well. And then also, a piece that Ken had also mentioned is their personal care team. So this is not a, obviously not clinical, but these are the people that are their family, their friends. A lot of times, they don't understand some of the information that's being presented or being asked, or the situation they're in. So they need ability to be able to communicate and share information and grant information to their personal care team. So we've set them up with the ability to set those and then being able to add them as well, and being able to not just be able to set them up, but also be able to pull them in at different times as needed. So what we're going to go into here is, for example, we'll go into their events. And for those patients that see or prefer things as a transactional event-based view, we are showing them all the events that they have at this point in time. So you have archived events that are finished and closed. We have events that are active, and then we have things that are updated, and then new events. So, for example, a new referral. With these, the patient can drill down into individual ones and get more detail about it. So, for example, if they were to look at what we viewed as the originating initial visit to PCP, you can click into that and then basically view the details for that particular activity. So you can see the fact that the primary care physician, you can see the date the appointment was made, and you can see the doctor's note as well as their information that they provided. You also have the ability to provide any notes in terms of the referrals, if there were any, or instructions for that patient, if there were any as well. Also, ability to see all the types of information that was accessed and possibly used during that time. One of the things that we also put in place is ability to view the patient consent. So this is part of the consent management that we want to put in, is going, hey, yes, this patient gave consent to this physician or this health system, and therefore we want to track that and show that fact that this was given. We also want to give the patient the ability to provide feedback post or post their appointment or during their treatment plan. So on this part, they would just type in additional information and then submit feedback, and then that would be something that the physician can view, will be alerted to, can view what was added in, and then read up on that. So this one, for example, is just all into, it was be submitted, and it is basically secured within this event and purely for this patient. So no one else would be able to see this information except for this patient and the team members that were involved for this particular event. So in this case, the medical healthcare team that were involved in this particular event are just what we say this part is the primary care physician and the oncologist, as well as the person's husband is what we're saying. They can go in and add additional ones. For example, if they want to include their sister in here as well, they can go ahead and do so to be added in to this basically team. What we've also put in place is ability to chat. So one of the biggest things that we were trying to look for is a way to communicate, not having to jump onto the phone, being able to also not have to get into in-person, person-to-person type of conversation. So one of the things that we're looking into is basically how can we go about and making a secure messaging system that is only available to the people that are involved. So while their care team might have been those initial set of people that were added in, the chat is different. The chat also still has its own security layer of who can view that chat. Because even at that point, even if they have sharing of information, we don't want to say that they all have access and view of that as well. So the way we set this up is that the chat has that whoever initiates it, whether it's the primary care physician or the patient themselves, it is directly to that primary physician for that particular event. So in this case, the PCP. Now, one of the things that we're looking to add in the future, when you're talking about specific medical terminology, such as ALT or ALK, those type of things, one of the things we're looking to add is more of a dictionary that can be done in that can be tapped on, and a definition, examples, readouts can be provided to that patient so they can find out what that actually means. The other thing that we're looking at into this system is the ability to identify who you also want to add into this conversation. So if they wanted to add in, for example, their sister into the conversation, they can do that, and that person will be notified that they've been added to this chat, granted permission to continue and see the chat, and then make conversations in here and communicate with the people that are involved in this chat as well. This is what we coined that terminology. The way that we are looking at it is similar to maybe the way Slack works, that you can create these custom channels along those lines. So one of the biggest things also we had is that if you look into the actual details for this particular one of the ways that we looked at is that as a patient, they can go through and look at all the activities that kind of pertain to this particular flow of events, and then all the information on that one. And they would be able to see what had transpired for that. So this is a view of, for example, that one particular event gone through from the all events listing. The other avenue that can go through it is through the medical healthcare team, where you click on, for example, oncologist right now. I will click on, and you will see information details for that oncologist. So over here, you'll see the primary care physician who referred them, and basically you'll see the appointment date or the date that was made. You'll see the doctor's note and instructions for the patient for their appointment. If there were instructions previously, it will still be there as well. So one of the things that we also want to provide for the patient is the ability to see that what information was shared between the PCP and the oncologist. So you can see a subset here, but you can view all to view more of that information of what was shared between the two physicians or the two systems. So this is one of the items that we have. And then over at the bottom, what we are showing here also is, like I said, the personal care team, ability for you to add additional ones, and same thing for the medical healthcare team too. What I also want to show you next is the physician's point of view. So this is the patient's point of view. The physician, what they'll be going through as I prepped up the username and password, is their initial login would be able to see all the different from top to bottom. And we made up quite a bit of this, is just the, and hopefully no one would ever see something like 42 alerts or 51 for the patients. But what we're looking at is at the top, you would still be able to see your essential, your healthcare systems, like basic set of information of what's in your system, the numerical number, and depending on who you are, you'd be able to access it as well. So if you clicked onto the 10 hospitals, you'll see more information, and we'll see some of that view in the admin view. So for this, for example, if you were to go in and add additional patients, you can go ahead and add the additional patient in, and we'll go ahead and make something up at the moment. And then basically just state that if it was an in-network referral or out-network referral, and then basically just submit that for now. You'll see that I don't have an assigned patient in there. The ability for us is to go in and also make an assignment to that patient if we need to. Now, the view that we have over here are the patients that need attention. So you can go and get a list of your total patients, but these are the ones that have an immediate need or urgent need to be viewed and to be responded to. Our data right now being test data, we were playing around with trying to find a threshold. One of the things that we want to provide is the ability to allow you to custom set up your own thresholds. So as you can see here, we're not quite there yet in terms of the numericals of the coloration, but we're looking at ability to go and say, hey, at a certain point, things shift from, okay, you should be worried, to this, you really need to pay attention and do something about this. So in this case, we're going to go with Jane Watson, who is our patient from our initial app. And if you click on there, what you'll see is a lot of the same information that was also available to the patient herself, with some minor differentiation. So you'll see the history of what that patient saw as well, all the events leading to it. And then what you'll see is basically the workflow for the referral, and all the different steps that were taken, where they're at, all those type of things. We haven't built out basically the ability to go into any individual one yet, but that's what we're working on to get into next. On the right-hand side, you will look at the relationship from the physician's point of view of the patient and all the different physicians they have access to, as well as all their personal care team. Now, what you'll see is that this particular gastroenterologist is grayed out because they don't have, the patient has not given consent to this referral yet, whereas they have given consent to Matt Smith. So if you were to click on that, you would see the fact that consent wasn't given, so you don't have access to view any of that information. If you had access, you'd be able to view that information. You also have access to the chat here as well, in terms of what you have been talking with that patient about. So if we were to go back right now to the patient's point of view and basically add in, for example, a physician. We'll just go ahead and name this one Mary Jones. We'll say this date, and we'll say, actually, I think we'll say acupuncturist. And then if you say yes, we'll submit this one. Okay, great. What you'll see is that an additional person is added to that view. And what you'll see for this one, what we saw is gastroenterologist is grayed out. So if we go into the gastroenterologist right now, what you'll see is basic information about her as well, but you also see that the consent here is, the consent is needed from the patient. So what we were stating in this flow is that because this particular physician is outside of the health system, that you would need specific consent. So right now I have, the patient has not given consent yet. So we will go ahead and give consent for this patient here for that particular physician. Well, and that was an error right there. Some things are still being tweaked on a little bit. So theoretically, what would happen is that would have been given, and essentially what would happen over here is what you would see is, well, it looks like it was given and just didn't go through, and we didn't see the correct screen for it. But then you see that she's no longer grayed out, and you have access to her information as well. And you can see the new acupuncturist on here has been added. And you can see on the event side that a new event was created in that history for the acupuncture to be created and that visit created. So one of the things that we want to try out to play and show is effectively the relationship and the security data being transferred and all activities, so you can, a physician can review and have complete scope of understanding that they're allowed to and that they can respond to, so they can communicate without having to wait. If we then move into the admin's point of view, the administrative admin for the system. So this is a rough viewing of the data that we've put together. Essentially what we're trying to do here is provide a very quick view of the health of the system. So one of the biggest things that we want to be able to show is, for example, for any particular hospital in that system, we're saying there are 10 hospitals, of all the activities, which activities are in good standing, which activities are in warning, and which activities need immediate attention, which is where the green, yellow, and red stands for. So we're still working with the basic UI of this, but we have the data in at least to help us generate and tweak those. So of those, you can also see what we're trying to show is the different care team members as well in that. And what you're trying to do in this view is show the care team members that need attention to. So in terms of performance. So in these are in alert. So if they are doing really well, performing really well, you might not need to have that immediate attention to it from an admin's point of view. But for a care team member that requires, for example, performance or needs to find out what's going on, for someone who has 12 issues that need attention, 9 issues that are that possibly delay or have problems, versus 9 that are good, then they might need immediate attention and immediate access and communication. So we provide this as a quick snapshot, and then we have the ability to, what we're trying to build out is the ability to drill down to show all the activities associated with that particular physician or that particular hospital. So again, reduction in the navigation scheme, but more in terms of in context. If I'm looking at a hospital, I want to drill down specifically to the hospital. And the same thing over here, it happens to be the patients that need attention. Similar to what you saw in the physician's point of view, but now this is across all the physicians, whereas in that physicians across them and their staff members. One of the things that we have on here, we have not plotted this out yet, but we're working on that at the moment, is the ability to look at going through all our data to compare the in-system versus out-system referrals, their trending pattern, and that way they can make adjustments and adjust how they're performing. see how each, whether it's in-network or out-network, and how their performance happens to be in comparison, all from the admin's point of view. So that's basically the full demo there, and I'll give it right back to Ken.
Thanks, Ty. 1 second, let me go ahead and take this. Sorry.
And while you do that, this is Tracy. Feel free, everyone in the audience, if you have questions, you can add them in the questions box. I know there was one, and Ken, you hopped in there and answered, but feel free to submit questions.
Yeah, please do. And to Ty's point, just to quickly revisit, specifically in the admin screen, these elements that are coming together that we're measuring against, we're using industry standard KPIs, KPPs for the majority of the referral types as a baseline. As we engage clients, the intent is to leverage their own KPIs, KPPs that they have for treatment outcomes, for timelines, for referral timeframes. What is acceptable? What's the expected turnaround time? How many visits are normally tied to this sort of treatment? We use those as the baseline, and we're able to provide them visibility into, to Ty's point, where there might be gaps, where there might be training opportunities, where in fact there are disengagements between systems or between providers. So it provides that visibility across the system. And to be honest, we built that out because we need it for health flow in general. But in talking with system providers out there, different CTOs, CIOs that we've been able to engage with, it's certainly something that they're looking for, to provide that visibility, specifically whenever we start talking about ACO and other measures which are applicable to not only treatment but payment whenever we're considering that. So going back to just a quick review of the health flow product capabilities, what we've wrapped in. Again, it's standards-based. We're using standards-based APIs and clinical workflow processes. The intent there is to accelerate and simplify integration. Advanced model-driven parametric rules engine. Again, we're driving that off of the, in the case of the earlier reference to BPM Plus models that are coming in. They give us additional context. We take that, we combine it with general standards of operation and rules, and we apply that from an automated rules processing engine standpoint. The goal is to drive and improve care coordination through the patient-centric process automation. That detailed reporting that Ty just quickly ran through, that is against the customer-specific criteria and measures. Again, that is at both the system-wide as well as the doctor and patient level. You want to be able to provide that deep dive into how well treatment is going, whether or not everyone is meeting the patient outcomes, and quickly intercede where you need to ensure that your desired goals are met. Zero trust end-to-end encryption architecture, again, with that immutable transaction record. That's the one question that Tracy mentioned that came across was around blockchain. We were originally leveraging Hyperledger Fabric. We have since transitioned to Hyperledger Bezu, which is Ethereum-based. We've been working with Consensus to fully transition to that particular blockchain. It's more suitable for our particular environment. Transaction measures are far better. And again, that gives us that visibility at the patient level of exactly what's happening to the patient data, where it's gone, and what's going on with the transactions. If a GDPR request comes in, we have an end-to-end transaction record of everything that's happened, and we can reach out to the individual providers, let them know that that request has come in. Simplifies patient consent management, puts the patient in control of their health data. Again, that view that Ty ran through at both the patient and clinical care team perspective, having that visibility into where the data has gone and whether or not consent has actually happened is critical. And we've built it from day one to scale exponentially in real world implementations. That's also part of the reason that we're teamed with Wired Informatics, with Red Hat, is to give us that capability, that reliable infrastructure that we need to really meet market demands. We are both HIPAA and GDPR compliant. And again, at the end, supporting the evolving ACO value criteria. As we continue to move forward, CMS, ONC, and other organizations come out with these additional standards. It's critical for us to be able to provide the flexible implementation that can actually meet those standards. By abstracting the rules out, by leveraging things like BPM plus Health models, it's our goal to ensure that going forward, this is basically a future-proof architecture. We're able to plug and play components as we need to and drive better healthcare forward.
All right. I have a couple more questions if
Please.
you'd like. Yeah, absolutely. If when a new clinical workflow is published, how long would it take for you to incorporate that into your tool? How much work is involved?
Given that at the time that the engagement is initiated, we do a check against the library of what clinical flows are standardized and leveraged for this particular client. So there's a couple of checkpoints there. The goal would be, and again, it depends on compliance to standards. If there is some custom work that needs to be done, mapping, that sort of thing, that would have to take place first. But if it's aligned to the BPM plus standard, for example, the goal would be for it to essentially be automated. We can take the details, we can take the context, and that is also part of the reason that we're engaged with the BPM plus Health group, is to ensure that as this evolves, we are not only have a voice in the discussion, but secondarily, we can incorporate those changes into the platform as it moves forward.
Mm-hmm, mm-hmm. And thanks for your support in the implementer working group on
You're
that. Yeah. And then the next question, is this entirely outside of the physician's EMR workflow? Where/how are the physician notes generated that show in the provider view?
The intent is to implement this as a SaaS offering in between EHRs, EMRs. For those physicians, because we've obviously been talking with a wide variety of both groups as well as independent physicians, the clinical user interface could serve as the main point of interaction for the clinical care team. Otherwise, we're leveraging standard APIs, and again, that's part of the reason we have the relationship with Redox, to go ahead and push this information into whatever EMR, EHR is in place, being able to then pull that same information, being able to pull that treatment information out and make it available also for, again, across the care continuum. That's really what our focus is. So in relation to the physician's EMR workflow, that point of interaction would be at where you touch other providers in the use case that we walked through today. From a care coordination perspective, it depends on what system is in there, how we would interface within that care delivery cycle, if you will. But right now we're targeting care coordination both between providers within systems as well as outside of systems. That's really kind of the target area. So we would be interfacing with the physician's EMR workflow as it currently exists and pushing the information to it in a way that it can be understood and incorporated within the notes in the existing treatment cycle. I don't know if that answered the question fully. We're not trying to replace anybody's EMR EHR, if that helps.
Mm-hmm. Okay. So that's it for questions.
That was
thank you, Ty. I said that's it for the questions in the queue. And thanks everyone for joining us this afternoon. Just a reminder, we're posting the recording, the video, and the slides to our website. And the link is in the chat box here in GoToWebinar. On that link, you'll also see the schedule of events. We have 2 more sessions, demos from HIMSS 20 this afternoon that you can join. We'll start again in 15 minutes. But thanks again, and have a great rest of the afternoon.
Thank you all.